Good afternoon, and thank you so much. This afternoon, we are excited to hear Dr. Susan Teitelbaum discuss her research on developing a new occupational cohort that will serve as a comparison for health outcomes in the World Trade Center General Responder Cohort and may improve our understanding of the effects of 9/11 exposure and the potential for developing World Trade Center-related disease. Dr. Teitelbaum is a classically trained environmental and cancer epidemiologist and is currently the Deputy Director of the World Trade Center General Responder Data Center at Mount Sinai. There she works with the team on management and analysis of the big data repository that examines World Trade Center-related exposure and health-related data collected over the past 20 years from more than 40,000 9/11 general responders. Her research focus includes investigations of environmental endocrine disruptors in childhood growth and development and breast cancer. She has led and co-led several large investigations, including the Growing Up Healthy study, examining the impact of environmental exposures on early development among 1,200 young girls, and the Long Island Breast Cancer study, investigating endocrine disruptors and breast cancer. Dr. Teitelbaum is also the principal investigator of the Data Center for Human Health Exposure Analysis Resource. Human Health Exposure Analysis Resource provides laboratory and data analyses to add or expand the inclusion of environmental exposures in health research across the lifespan. This afternoon, please welcome Dr. Susan Teitelbaum.
Thank you, Melissa. So, I'm hoping everyone can hear me. This is the official title of the talk, Development and Implementation of a Comparison Occupational Cohort for the World Trade Center General Responder Cohort. But there is a far better title for this presentation, and it is The Best Laid Plans of an Occupational Epidemiologic Study Often Go Awry, with apologies to Robert Burns' poem To a Mouse that he wrote in 1785. And no matter how carefully a project is planned, something may still go wrong with it. And that is truly the case with the New York Area Workers Cohort. So I'm going to tell you a tale of how COVID-19 created havoc with the development and implementation of a comparison occupational cohort for the World Trade Center General Responder Cohort. So here's a little background. The toxic dust cloud created by the destruction of the World Trade Center, was composed of asbestos, pulverized glass and cement, lead, polycyclic hydrocarbons, dioxins, pesticides, heavy metals, and polychlorinated biphenyls. These exposures resulted in a large number of mental health conditions, respiratory disease, GERD, cancer, and sarcoidosis. Many hundreds of published articles in both medical and the lay press have addressed the health status of first responders, and indeed a large amount of knowledge has been gained about the extent of disease in the World Trade Center responders, as well as best practices regarding treatment. However, one of the remaining gaps in our collective knowledge is the limited ability to directly compare the general responder cohort to a similar yet unexposed cohort in order to understand whether the rates of disease being observed are what one would normally expect in such a group and whether they differ. Comparisons currently being done rely on general population databases, either national databases like NHANES or SEER programs or other more local data such as cancer registries in New York State or other nearby states. And these data sets are useful and have provided some beneficial guidance about the incidence and prevalence of disease in the general responder cohort. But for occupational epidemiology studies to be especially valid, it's essential that more appropriate comparisons are used. So to give you some perspective on the size of the general responder cohort, as of December 21st, NIOSH reports that there were almost 150,000 members enrolled in the WTC health program, and over half are WTC general responders. And just to note that general responders who are enrolled in the New York metropolitan area clinical centers of excellence, as well as the national program, are included in this group. So now you have some understanding the size of the cohort of the general responder members who are enrolled in one of the 5 CCEs. Almost 30,000, 58%, have been certified with at least one WTC related condition. And as of May 1st of this year, the most commonly diagnosed conditions are upper respiratory disease, GERD, obstructive airway disease, and cancer. And it should be noted that members with a certification, among the members of that have a certification, 24% have only one certified condition, while 20% have 6 or more certified conditions. So now you have some understanding of the wide range of health outcomes that need to be investigated among the general responders in relation to exposures that they received while they performed their rescue and recovery work. And as I said earlier, the key to conducting this type of research is to have an appropriate comparison group. So what is the correct comparison group? A fundamental aspect of any occupational epidemiologic study is an unambiguous definition of the study base or the study population. For the purposes of this investigation, the study base is the World Trade Center general responders. Ideally, a comparison group to this cohort is one that is exactly the same as the exposed group, but without the exposure. And barring such an exact match, one strives to develop a comparison group that is as similar as possible with respect to factors that could influence the outcomes, potential confounders, and one that has been subject to a similar degree of information collection. Similar medical protocols have been performed. In addition, the comparison group must lack exposure. This last requirement raises a problem that with using the general population for comparisons with occupationally exposed other populations, the general population may contain individuals who've had the same or similar exposures. In this case, it's less likely in terms of quantity, but certainly in terms of characteristics. And the general population also contains persons who are unable to work or unwilling to work due to illness or other circumstances, or because of different age ranges from the workers. And another aspect of considering the correct comparison group is the healthy worker effect. This well-known phenomenon entails workers exhibiting lower overall death and disease rates than the general population. And the concern is that such a comparison may lead to an underestimation of the exposure effect because the general population is less healthy at the start. The healthy worker effect undoubtedly looms large in studies of the general responder cohort as responders not only entered and worked in the hot zone, but did so knowing that the structure was physically unstable and that no survivors were likely to be found. So they felt they were healthy enough to do this. The healthy worker effect occurs because relatively healthy individuals, compared to older or sicker individuals, are more likely to be employed and therefore more fit for continued employment. There are several solutions that have been offered to manage, if not control, healthy worker effect. And the chief among them is not to use the general population as a reference group. The overarching goal of this study is to develop a comparison cohort that is valid and avoids the potential bias of healthy worker effect. And this will allow us to compare cohorts of employed persons who have the same or similar occupations, but one cohort was exposed to WTC hazards and the other did not experience such high-level exposure to a variety of health risks. And a recent and related example comes from the New York FDNY study, where they compared cancer incidence in the WTC FDNY with cohorts of firefighters from other cities. Thus, it's imperative that health comparisons of the World Trade Center general responders be against an appropriate comparator group, and no such comparator group currently exists. So now I'm going to take you through a quick summary of the demographics of the WTC general responders, and this will give you an idea of what we need to aim for with respect to the makeup of the comparison cohort. This map provides the location of the GRC members' current residence. And as you can see, the vast majority of the members live in the greater New York metropolitan area. This chart shows you the age distribution of the general responders on 9/11, those are the blue bars, as well as the most recent monitoring visit, those are the red bars, and among those who had a monitoring visit in 2021, the green bars. On 9/11, the mean responder age was 38.5 years old. 20 years later, it's no surprise that the mean age of the responders who had a monitoring visit in 2021 was 58.4 years old. The majority of the responders are male, and only 13% are female. Most members identified as being white or Caucasian, which was almost 50%. 8% identified as African American. 6% who did not report race did report that they were Hispanic. And the group other, which is a sizable group, comprised multiracial members, members reporting no race and identifying as non-Hispanic, and members reporting neither race nor ethnicity. The majority of members have reported completing college or having some college education, and only a small proportion reported not having graduated from high school. On their first monitoring visit, general responder members were asked about their occupation immediately before September 11th, 2001. More than half reported their pre-9/11 occupation category as protective services or military. Construction workers were the second largest category, and the most common other occupations were building and groundskeeping, management, healthcare practitioner, and technical and architecture and mathematical. Among those who had a monitoring visit in 2021, members were working full or part-time, were no longer the majority among the full general responder cohort, while the percentage of retired members climbed to 40%. So our cohort is aging, and we're seeing that reflected in their employment status. So now you've got a background of what the general responder cohort is. And now I want to present to you the specific aims of this project. So let's review these. Aim 1, Mount Sinai maintains a Mount Sinai data warehouse that provides researchers access to data on patients in the health system through the EPIC electronic health records. And it contains nearly 5.5 million patients with an encounter. And the database includes information on patient demographics, information on occupation is available along with age, sex, race, ethnicity. And the data warehouse also includes patient contact information. And with an approved IRB protocol, this contact information can be obtained. And so our aim was to create a database of Mount Sinai patients that would act as one of our recruitment sources. Our second aim was to build, utilizing the patient information that we would obtain from the warehouse, we would begin to build a new occupational cohort that would serve as the start of the comparison to the general responders. And it would be used in a longitudinal assessment of the responders' health and aging. So the recruitment would utilize contact information in the database that was built through AIM 1 so that we would be able to reach out and enroll people who were eligible for the study. And our third aim, once we built the comparison cohort, was to recreate an assessment that we'd done an investigation of GERD among the general responder cohort, but it was all internal comparisons because we did not have an appropriate external unexposed population. So the comparison cohort that we would build could be the comparison cohort, and we could perform the analysis to see if the results were affected by the fact that we did not have that comparison cohort. Excuse me. So studies like this would result in likely improved estimates of disease risk, and add important knowledge that we could help us to understand about the exposure to the 9/11 toxins and stressors. So the official name of our application, as it says, we first need to develop the cohort, which we named the New York Area Workers Cohort. And we developed a logo for the cohort, and the logo combines the geographic area, the greater New York metropolitan area, with the expectation that the cohort would include a wide range of workers with a variety of occupations and races and ethnicities, as well as both men and women. So to facilitate the completion, we had to have a study questionnaire, which would be collecting information that we would be able to use as baseline information on the comparison cohort. And to facilitate the completion of the study questionnaire, we used REDCap as the method to develop and capture all study-related information. REDCap is now widely accepted as an online method. It's very easy to use, and it allows for use on all different platforms. It's HIPAA compliant and very well accepted by IRBs for use as a data capture tool. So first things first, we had to make sure that people who were signing up for the study were eligible. And the key to being eligible for the New York Area Workers Cohort is to not be eligible to participate in the World Trade Center Health Program. And this was the most comprehensive way to enroll people who did not have WTC related exposure at the intensity of the general responders. Eligibility also required that the potential participant had to be either working or have previously worked. In other words, they could be currently unemployed or retired. And all participants had to be at least 18 years old. And to ensure that the information that we would be collecting on the New York Area Workers Cohort would be comparable to the World Trade Center general responders, we used the monitoring visit interviewer administered medical questionnaire, the IAMQ, as many of you know it, as the basis for our baseline questionnaire. We designed the questionnaire to collect information on demographics, medical conditions, diagnosed by a health professional, family history of medical conditions, reproductive history among women, as well as lifestyle behaviors such as smoking and alcohol consumption. Once the project got back up and running after the COVID pandemic began, we added an additional questionnaire module on COVID with the objective of gaining an understanding of how workers were being affected by the COVID pandemic. So before COVID was on our minds, we had several recruitment approaches planned that were included in our IRB protocol. The first step was to obtain approval to receive the patient contact information as well as other medical information from the Mount Sinai data warehouse. We plan to use this database as one of the sources of potential participants, sending those who appeared eligible an invitation. And if the potential participant was eligible, then they were provided with a consent form that could be completed over the phone with a research coordinator, And after providing informed consent, the participant was provided with access to the online questionnaire for completion. Simultaneously, prospective enrollment was planned where trained research coordinators would approach patients who attended the Selikoff Clinic to discuss the study goals and consent issues. They would assess eligibility and, if eligible, obtain informed consent. And then they would provide the new participant with a link to the online questionnaire. We also plan to conduct outreach enrollment by using the outreach resources available through the Selikoff Clinic. We plan to recruit workers in occupations that are among those of the World Trade Center general responders, such as law enforcement. And as I'm sure many of you have experienced, obtaining IRB protocol approval took a great deal of time. And we finally obtained approval shortly before the COVID pandemic began. So in comes the COVID pandemic, research is shut down, and it's clear that we're going to have to make a major pivot in our approach to recruiting participants. First of all, in-person recruitment was no longer an option. We realized that our method of obtaining e-consent was not remote e-consent, so we would have to find a better method, and I'll give you more on that in a minute. Next, we'd have to find more ways to reach out to the Mount Sinai patients that were in our database. We'd have to develop a social media presence. Once we were able to work all of this out, we had to submit an IRB protocol modification. And once again, it took many months to attain approval for these changes. And it wasn't only because our approval was complex, but because COVID just kind of wiped out their ability to be able to handle all of the protocols that were coming in. So for the next section of this presentation, I'm going to take you through the learning and implementation process that was sometimes quite frustrating to adapt to the COVID pandemic and doing occupational epidemiologic study participant recruitment. So here's the evolution of remote e-consent. E-consent is a multi-purpose, scalable, electronic informed consent system that can be used in a multitude of settings. The platform allows for uploaded multimedia information about a research protocol to be put together with an approved informed consent. These materials are then delivered to the potential study participant electronically in an easy to understand and user-friendly way. The system is compatible with a wide range of devices and display sizes, including tablets, mobile devices, laptops, desktops, and other formats. When we started developing the participant recruitment and enrollment protocols, it became clear that we needed to find ways to accommodate the variety of situations in which participants would be interacting with the research staff. And this is our timeline of the incorporation of e-consent into our study protocol. We started using emails to potential participants and simultaneously developed the first approach to e-consenting, which was a system developed at Mount Sinai called iOpen, which stands for Online Patient Enrollment Network. And it was specifically developed for consenting Mount Sinai patients for clinical trials and other research activities. Since email was not generating the volume of response that was sufficient, we then incorporated a texting mechanism called Twilio. And REDCap was then used as a secure web application for building and managing the online surveys and databases. And the fortunate thing is that REDCap allows you to integrate the use of Twilio so that we could reach out to potential participants through text messages. When we continually encountered problems with iOpen for obtaining e-consent, we then investigated and ultimately adopted REDCap for obtaining remote e-consent that proved to be less problematic. And each of these modifications required IRB approval. I know I sound like a broken record, but IRB is important. So let's go a little bit into IOPEN so you can get an idea of what we were dealing with. So because remote e-consent is going to be more common in epidemiologic research, not only because of the pandemic, but also because of the convenience, I think it's important to provide you with this in-depth description. IOPEN is interactive, and it's an electronic enrollment system that presents research study consent documents to the study participant. A potential participant is guided through each individual component of the consent form, either remotely or aided by a study team member, including the signing of the document. And a staff dashboard provides the study team members with access to the signed documents or to send email invitations. So I want to give you a few of the pros and cons of using this approach. So I have to say that the concept of e-consent really impressed me when I was first introduced to it. My field experience with the recruitment of study participants for epidemiologic studies has always included informed consent. And the way that e-consent allowed the elements of the always long consent form into small digestible pieces increased my confidence that the study participants were gaining a better understanding of the study protocol and what their participation would entail. It was always so time consuming to present a paper consent form to a participant and making sure that they were hearing each of the elements and understanding it. And this way, a participant can do it at their own speed and have it presented in a very easy to understand module. The e-consenting process allows for both a summary version of each section of the consent, as well as an option to view the entire text. E-consenting allows for interactive questions about the study-related topics, which allows an assessment of participants' understanding. And the platform provides a signed consent document, and it stores so that it can easily be accessed by study staff through a dashboard. We can also verify the identity of the participant, and it's done through a use of a combination of a unique link and a passcode. So these are all really great elements of the use of e-consent. But there are some downsides. Because IOPEN is built on its own platform, participants need to navigate multiple platforms to go from start to finish. The potential participant needs to go to REDCap for eligibility determination, IOPEN for consent, and then back to REDCap for questionnaire completion. There were technical changes to the system that required the submission of tickets to tech support, and their response was slow. And it introduced recruitment delays if the problem was complex. And we also found that the platform itself could be unreliable. So we also found out that we couldn't distinguish participants who were unable to complete the consent from those who did not want to participate. So there was no opt-out information. And participants may stop completing the consent process. However, the system can't send reminders to participants who did not complete the consent. And when study staff would send a new email, the link was regenerated with a new passcode, which was then found very confusing for participants. So it was more the system than actually the concept that led us to find a solution for replacing IOPEN with another approach. So before I get to that, I want to talk about another great invention for reaching out to potential participants. And as I mentioned before, Twilio. It's a communication platform, and it's designed to improve engagement between the sender and the recipient. And this had been suggested to us by one of our co-investigators to use. It's versatile, it has many forms of communication. We chose the texting mechanism, And REDCap, fortunately, has been upgraded to incorporate a link to the Twilio mechanism, and that made it ideal to use for our project. So, as with all technology, there were some pros and there were some cons. So using Twilio with REDCap to contact potential participants and obtain e-consent had some strengths. Because of its integration into REDCap, it enabled us to send invitations to complete a consent via a REDCap link. This approach allowed study team to control distribution of consent, as well as the ability to rapidly fix minor problems and implement changes, because it didn't require a ticket to the tech support. Any questionnaires or information can be distributed in a mobile-friendly manner, and participants can complete all aspects of the study on the go wherever they are. So the other bonus was there's an opt-out function so that participants can indicate that they are not interested in receiving further contact or participating in the research study. And that's critical because we don't want to bother people who are not interested in participating, because it doesn't produce anything useful. Recent and up-to-date contact info, such as email, can be provided by the participant after they express interest, so that we can make sure a lot of the data that was obtained through the data warehouse turned out to be not updated and non-functioning. So if we reached someone, we were able to confirm our contact information, which was great. And if changes were made, the participant could continue to use the unique link that they were given to access updated questionnaires, which again was a much more streamlined way for people to continue their participation easily. But Twilio does have some of its difficulties. It, first of all, requires an application to be submitted that verifies the sender's phone number and nonprofit status. Okay, we did that. And since our database contains both landlines and cell phone numbers, the lack of ability to distinguish between these two types of phones is a problem. Twilio only sends messages to cell phones, but landlines can slow down the queue. And we pay for the message segments, which can add up when thousands of messages are sent. Fortunately, nonprofit and verified senders do receive discounts, and we took advantage of that. But the text message content, as everyone knows who text messages, is limited in size. So the question arises, emails versus text messages. Remote communication with potential participants was the only way that we could recruit for the study once the pandemic began. And our options were emails and or text messages. For these two approaches, each has their strengths and weaknesses. With respect to sharing of information, email addresses are not necessarily unique. They could easily be shared. And while text messages are likely not to be shared, phone numbers can change. So we have a problem with just the actual contact information. Communication success. Email messages can be sent to spam, while text messages are filtered at the network carrier level. However, Twilio offers the ability to verify phone numbers to avoid these filters. And there's the communication rate. Email has an unlimited sending rate, while text messages can hit bottlenecks depending on the provider messaging rate. There's participant engagement. We found that emails had a lower engagement than when compared to text messages. And cost. Email is free. It's without barriers to utilization, while text messages have fees associated with it, as well as additional paperwork that needed to be submitted for full utilization. So here is our sort of final recruitment flow that we developed in response to our restrictions due to the pandemic. So we had a long learning process where trial and error showed us what worked and what didn't work. And here's how it goes. We text invitations to participate in the study via Twilio. Those who are interested complete the eligibility questionnaire via REDCap. If eligible, the potential participant begins reviewing the e-consent modules and provides their electronic signature if they want to participate. They receive, upon signature, they receive a confirmation email and a link to the electronic survey, and then they proceed with completing the study questionnaires. So we needed to find ways to, so here we go. So we solved how we can best obtain e-consent and remotely recruit participants for enrollment in the study. But we wanted to find ways to increase our presence outside of emails and texts. Based on consultation with many people, including our external advisors, the Selikoff Center Advisory Board, member outreach at Selikoff Center, we put together a resulting media toolkit. The toolkit was a wide range of messaging that can be provided electronically to anyone who is willing to spread the word about our study. And it includes social media messaging, email and text blast samples, PowerPoint slides, literature for outreach, offers of study team presentations, as well as provision for enrollment assistance, as well as graphic elements that could be used on various websites. So let me show you some of the examples of this work. So here are sample media posts. So these are the kind of, these can be put on Twitter, or they can be text messaged. We do offer a monthly lottery for a $50 gift card for participants who have completed the questionnaire. We can't give every, because of the budget, we couldn't give every participant a reimbursement for their time, but the IRB allowed us to be able to have this lottery for the $50 gift cards. Things like, get to the heart of why we're doing this, help us study the health impacts of 9/11 first responders, and enter a $50 gift card raffle. So as you can see, we try to sort of synthesize what participation is and reach out, hopefully, to people who are interested in helping with us understand the responders' health problems related to 9/11 exposures. Our next is a PowerPoint slide that we put together. This is approved by the IRB to be used in outreach presentations. So there were a few times where we were given a minute or two in a larger presentation to talk about the study, and this slide sort of summarizes again exactly what we're looking for and gives people a very easy QR code to go to our website, telephone number, email address, the actual website, and emphasizing that this can be done totally remotely. There's no clinic visit required, and hopefully entice people to think about finding out more and joining the study. We have posters. So these posters could be put up in different locations where there may be people who are sitting in a waiting room and want something to look at. And so again, the summary of the study, QR codes, so it's easy to find out information, as well as other typical methods of contacting our study. And then there's visual elements. So if somebody wants to put this on their website, we put together different formats of the same concept, our logo, and keeping, people understanding about the New York Area Workers Cohort. So I just want to step back and talk about the real scientific impact of being able to build this cohort. why are we doing this? It's critically important for us to have valid estimates of the health of the World Trade Center general responder cohort. The use of general population comparisons can lead to bias and incorrect assessments for WT exposure effects on the health of the responders. We need a working population as a comparison. There's no doubt that the exposures experienced by the responders have led to many serious health outcomes. Increasing our understanding of these exposure-related associations will hopefully lead to improved estimates of health among the responders. So, as I said in my opening slide, the best laid plans often go awry, and COVID brought our study to a grinding halt. But after the dust settled, no pun intended, we assessed the situation and worked towards a protocol that would allow us to have the recruitment continue. We hit many speed bumps and road barriers, but we have been able to navigate each one with protocol modifications and enhancements. Although we are nowhere near the recruitment numbers that we had originally proposed, our enrollment has increased, and we remain optimistic that through the coming year, we have to thank CDC for providing us with a no-cost extension so that we have one more year to try to build our numbers. We will be able to make significant progress in enrolling New York area workers so that we can build a much needed comparison cohort for the World Trade Center general responders. We welcome anyone in the audience who might be interested in advertising the study, who might have suggestions for improving our enrollment, or would like to enroll in the study themselves, to please feel free to contact me or the study coordinator, or just scan this QR code and it will take you directly to the website. But none of this could have happened without the work and input of our project team. Carolina Valley, who's the research coordinator extraordinaire, and without whom we would never have succeeded in the face of COVID. Excuse me. Agata Bednarska, she's the Outreach and Education Program Manager at Mount Sinai Selikoff Centers for Occupational Health and the WTC Health Program Clinical Center of Excellence at Mount Sinai, has been an incredible source of assistance with the recruitment effort. Doctors Ismail Nabil and Homero Harari, both co-investigators, have worked with us on the questionnaire and protocol development. And our advisory board, who has given us guidance and input in navigating in the face of COVID, Patricia Kovach and Mike Crane, the advisory board of the Selikoff Center for Occupational Health, who has given us feedback and allowed us to present, and of course our funder, the CDC, without whom we would not have been able to undertake this project. So thank you. And again, reach out to us if you have any ideas, any suggestions. We are very open to listening to them. Thank you very much.
All right, Dr. Teitelbaum, thank you so much for doing this. But I want to thank everybody for participating and for being here today. And we're going to sending out an invite for the August presentation that's going to be coming up. Dr. Teitelbaum, thank you again. And thanks all of you who took time out today to participate. Have a good day, everybody.